Hello everyone. Uh, Good morning, good afternoon, good evening, and good night. For I think a lot of people would be joining from different time zones, and as always, those who have been attending our webinars since past couple of months, I would like to introduce to you about this pediatric respiratory critical care series webinar. And this is a new initiative of the World Federation of Pediatric Intensive and Critical Care Society's Education Committee, and we bring into you experts in the field of respiratory critical care medicine from across the globe. And we have been getting a very fabulous response since last couple of webinars. And on the same note, we have planned the next webinar on the topic lung as a spring: compliance, resistance and work of breathing, with our fabulous faculty. And before we introduce our faculty, I would like to take a brief moment to introduce our team of respiratory critical care subcommittee. So I am Dr. Milind. I also chair the World Federation of Pediatric Intensive and Critical Care Society's Education Committee. I am the medical chair. With me is Georgina. She is the chair for the AHP for the WFPICCS Education Committee. We have Dr. Abdul Rahman. He is one of the moderators and respiratory critical care subcommittee members. With him we have Dr. Michael Canary. He is also a member, and we have been working very hard to get all the expert faculties from across the globe. And today one of our other committee members, Dr. Farhan Sheikh, is not available because he's traveling. So that's what's a brief introduction about our subcommittee, and I would like to hand over to Georgina to introduce our fabulous faculty and take it forward.
Hello, everyone. I'm delighted to introduce Dr. Alberto Medina, who is our speaker tonight. Alberto tells me he is first and foremost a diving instructor, but he's also a PICU full consultant at the Hospital Universitario Central de Asturias in Spain, with over 25 years' experience in pediatric and neonatal intensive care. He's the editor of 10 books, 6 focused on mechanical ventilation and 3 published in English, and the author of over 100 articles and 150 international conference presentations. Alberto has taught and coordinated more than 150 courses in CPR, pediatric trauma, transport, medical simulation, and mechanical ventilation worldwide, including Kuwait, Israel, Australia, Portugal, Switzerland, Turkey, Egypt, and the UK. Dr. Judith Wong is our guest faculty tonight and is a pediatric intensive care clinician scientist at KK Women's and Children's Hospital in Singapore, whose work combines clinical epidemiology, multi-center regional studies, and immunological research to improve understanding and treatment of respiratory failure and critical illness in children, particularly in the Asia-Pacific region. Thank you, Dr. Medina. We'll let you carry on with your talk.
Oh, thank you very much for this nice presentation. I would like to thank to all the team for inviting me, and in particularly Abdul Rahman, who is my friend. We met together sometimes for different courses, and just for inviting me to talk today and discuss about one of my favorite topics, which is the lung physiology. And my first slide is this. Probably you know very well the respiratory system on the right-hand side of your screen. But my objective today is to understand the respiratory system not like this, alveoli connected with airways, but more like, as you can see in the left-hand side. This is that spring connected to a damper or resistant chamber, or something like that, which is the name of these, probably you know from a long time ago, this is the Maxwell body. And this is my objective, to understand the respiratory system like this model. So the outlines for my talk today are 3. One is to review the static properties of the respiratory system. Second, the dynamic properties. And finally, I want to mix together both properties and the two constant, compliance and resistance, in just one constant, which defines the respiratory system. And this is the time constant. For me, it's the crucial concept to understand better the strategy that we need to do the things better with our ventilation, evaluating different patterns. Well, let's go with the static properties of the respiratory system. And to introduce this concept, you need to review two formulas. So the most important formula related to the movement of the air from outside to inside and vice versa in our respiratory system is those formula on the bottom. There's a transpulmonary pressure. And the transpulmonary pressure is the difference between the alveolar pressure and the pleural pressure. And of course, we have another formula, is on the left-hand side, is the trans-chest wall pressure, and which is the difference between the pleural pressure and the atmospheric pressure. But from a practical point of view, I would like to focus my attention mainly in the transpulmonary pressure. For a better understanding, as I know that this is very difficult to do this talk, thanks to Vicente Modesto, one of my colleagues, we do this talk and to present this talk many times in different courses, but I try to just to play the game with you, with the audience, first of all, with this experiment. Imagine you exhale the air until the residual volume, and at this point, you maintain a prolonged apnea whilst keeping the glottis open. My question for you is, what would alveolar pressure be in this condition? I know that you cannot answer this question physically, but I give you just 2 seconds to think in that. The answer is very simple, because the alveolar pressure is 0, because our lungs are connected when the glottis is open to the atmosphere, and we consider this atmosphere, the atmospheric pressure, as the 0. It's like when you perform a 0 in your arterial line. We connect this arterial blood with the atmosphere, and the result is 0. Afterwards, we can measure the arterial pressure. And imagine in this moment, we measure the pleural pressure, for example, using an exophageal catheter, like in this case. My question for you, second question, is what would the transpulmonary pressure be in these conditions, considering that the pleural pressure measured with this transducer is -3? The answer is very simple, because we can just remember the formula. Transpulmonary pressure is the alveolar pressure minus the pleural pressure, considering that it's minus is positive. So the transpulmonary pressure in this case is 3. I'm going to draw some points on this graph on the right-hand side. And in this graph, as you can see, I'm going to represent different volumes, different lung volumes, but in a percentage. I do this in this because using this percentage of the total lung capacity, I can compare different size of patients. For example, newborns compared with adults, and as we are going to see later in some different presentations, different slides. And in this case, I'm going to represent the residual volume with this transpulmonary pressure, +3 on the right-hand side. The second experiment can repeat exactly the same experiment, but not just moving the tidal volume. When you exhale completely the tidal volume, we can measure the pleural pressure, and in this case, in the exophageal catheter, we can measure -5. This is a real value. We open the glottis, so the alveolar pressure is 0. And the question is, what is the transpulmonary pressure in this case? And you have the solution, just remembering the formula of the transpulmonary pressure. In this case, is +5. If we repeat exactly the same experiment, but inflating the lungs up to the total lung capacity, and the pleural pressure in this case is -30, the glottis is also open, so the transpulmonary pressure is +13. And you see in the graph that I represented the 3 points, and I can draw a line between these 3 points, which is in really, this is a curve. And this is the curve for the lung, for the alveoli, not for the chest wall. We are going to review the chest wall later. But the summary of this part is that the lung volumes only change when the transpulmonary pressure changes, not with the alveolar pressure on its own. And the table summarizes the 3 volumes that we review. One is the residual volume. We need a positive pressure of 3 centimeters of water to inflate the lung up to the residual volume. We need a 5 centimeters of water to fill the lungs up to functional residual capacity. And we need 30 centimeters of water to inflate the lung up to total lung capacity. In the middle, we have different tidal volumes, but we don't have a name specifically to define the functional residual capacity plus the tidal volume. With the normal tidal volume can be 6 ml per kilo ideal body weight. And in this case, the transpulmonary pressure to fill the lungs with the tidal volume above this functional residual capacity can vary between 12 to 18 centimeters of water. These are normal values, and we are going to see that this corresponds with the plateau pressure. The clinical consequences of these concepts. For example, in an intubated, sedated, and paralyzed patient, what is the PEEP which should be set to maintain the functional residual capacity? And get 2 seconds to think deeply in this point. If we represent a patient intubated and under neuromuscular blockers, the pleural pressure will be 0 or very close to 0. The alveolar pressure will be 0, also 0, because the glottis is open and because we have a endotracheal tube in the trachea. So, in other words, if we want to recover the functional residual capacity, we need to introduce an alveolar pressure of 5 to maintain the transpulmonary pressure in 5. Don't forget that every single volume represents every single transpulmonary pressure. In other words, in an intubated, sedated, and paralyzed patient, the PEEP necessary to recover the functional residual capacity will be 5. So God said the PEEP. But you know probably very well this X-ray. This X-ray represents the X-ray of necrotizing enterocolitis in a patient, and you can see that probably the abdominal pressure is very high and is pressuring the lungs to the top. And you can see that the lungs are very, very small, very, very small. My question for you is how much alveolar pressure, in other words, PEEP, is necessary to recover this lung up to the functional residual capacity? Do you think that 5 centimeters of water are enough to recover the functional residual capacity in this patient? So probably not. And maybe you need 10 or 15 centimeters of water to recover, just to recover total lung capacity. And this is very well connected to the next slide. So this is another example. Imagine we inflate the lungs, in this case in a trumpeter, and we inflate the lung up to 15 centimeters of water. Don't forget that this pressure represents a normal tidal volume. And at that moment, we perform a Valsalva maneuver like this. If we can measure the pressure inside of our trachea, our mouth, probably this alveolar pressure increases up to 50 centimeters of water, 50. My question for you is, what is the pleural pressure in this situation? And if we remember again the formula, the pleural pressure in this case is positive. And if you do that, in your case, you can feel that your diaphragm is pressuring your abdomen and your thorax. So the pleural pressure is positive, but the transpulmonary pressure is also plus 15. We don't have any variation. If you analyze deeply this concept, this means that, or you can obtain the conclusion that the barotrauma theory is false. I'm sure that you are opening the eyes like this, thinking in that. But if you consider that the barotrauma theory is based on the more alveolar pressure, the more lung damage, the more Billy, ventilation-induced lung injury, in this case, the theory is false. And this is not new. I found this paper published in 1969 in Nature, and as you can see here, the pressure necessary to play the trumpet in this case is up to an alveolar pressure 150. And this is very nicely summarized in this paper published 13 years ago by Slasky and Ranieri. And in the D example is exactly the example of the trumpet player with a transpulmonary pressure in between 150 to 140. In other words, it's difficult to believe that the theory, the classical barotrauma theory is true. Well, summarizing these points, which represented the functional residual capacity, residual volume, and the total lung capacity, on the left-hand side, you have a curve, the green curve, which represents the behavior of the lung. But on the left-hand side, you have the purple graph. This is the behavior of the chest wall, and it's completely different. When you maintain isolated both parts, the lung always tends to the collapse, but the chest wall always tends to the expansion up to the 75% of the total lung capacity. After this point, the tendency of the chest wall is to the collapse. When we connect both things together, both things that of the respiratory system, the lung and the chest wall, we can obtain the red curve. On the left-hand side, you have the behavior of the respiratory system in an adult. And if you can continue the purple graph and the green graph, you can see that, or you can identify a point in which the tendency of the collapse of the lung and the tendency of the expansion of the chest wall have the same magnitude. And this is the rest volume. And this is a concept, an anatomical concept. And this coincides exactly with the functional residual capacity in an adult. So one anatomical concept coincides with a physiological concept from pneumology. And this is the normal thing. We want to, the adults, we want to ventilate above this functional residual capacity. And this is a very good objective for our patients. Ventilate all of our patients above the functional residual capacity. The problem is in newborns. In newborns, we have a problem with the chest wall. The behavior of the lung is the same as in adults, but the chest wall, the tendency of the expansion of the chest wall, you can see, I read in many books, in many papers, is close to the infinite. It's a joke. It's parallel to the y-axis. This means that if you try to identify the point in which the tendency to the collapse of the lung and the tendency of the expansion of the chest wall is below the functional residual capacity. In other words, the rest volume is below the functional residual capacity. This means that the newborn needs to waste energy actively to recover the functional residual capacity. The newborn wants to ventilate above the functional residual capacity, but the nature tries to collapse the lung. In other words, we need two active mechanisms. One is the diaphragmatic contraction at the end of the expiration. And the second mechanism, you know very well, this mechanism is the grunting, like this. With the grunting, the patient wants to produce air trapping. And with this air trapping, the patient is going to increase the alveolar pressure. In other words, to recover naturally the function residual capacity. The characteristics which summarize all these static condition of the respiratory system is the compliance. Is this a constant defined between the relation established between the volume that we introduce in the lungs, which is the tidal volume, and the pressure related to or necessary to maintain this volume inside of the lungs. Measure always in static conditions. So we need to perform an inspiratory hold and an expiratory hold to measure the bladder pressure and the real peak pressure. When we review this graph, I know that that you know very well this graph. This is a pressure time graph curve in volume control mode. You can identify the bladder pressure and the peak pressure, and the difference between one and the other. It is the famous driving pressure. So it's a concept described by Marcelo Amato 10 years ago. I don't have enough time to explain deeply this concept, but this is the subrogate of the compliance. And we are going to see later that the difference between the peak pressure and the plateau pressure represents the resistance. The normal value of the compliance is between 1 to 2 mLs per kilo and centimeters of water in children. Well, and this concept is very useful to identify. If we can draw this graph, this is the pressure volume loop in a static condition, we can identify 2 points on this graph, the lower inflection point and the upper inflection point. And the lower pressure inflection point represents the functional residual capacity. And the upper inflection point represents the total lung capacity. Our objective in every single patient under mechanical ventilation in the world is trying to ventilate every single patient in between these 2 points. Well, and this is a good example because my question for you is, should we ventilate all patients with a PIP of 5? Well, it is clear that, as we explained previously, that in a normal patient with a normal pattern under mechanical ventilation and sedated and paralyzed, the normal PIP, which recover the function residual capacity, which is the objective, is 5. But what is going on in asthmatic patient? A patient with asthma have air trapping for sure. This means that naturally the patient is going to breathe above this function residual capacity. So probably we need less PIP than in a normal pattern. Even more, the recommendation published by Tuxen in the early 90s is to set up for the very beginning, a PIP of 0. And afterwards, you have to evaluate the auto PIP produced by the air trapping. On the contrary way, when we have a very collapsed lungs, for example, in an ARDS condition, we are sure that we are going to need more PIP than the normal one, which is 5, probably 10, 15, or even more PIP. Well, in summary, the volume of the lung changes only if we change the transpulmonary pressure. And the second consequence of that, this static condition, is that we should try to ventilate our patient between the lower inflection point and the upper inflection point, avoiding the de-recruitment and avoiding the overextension of the patient. The second part of the talk is to review the dynamic properties of the respiratory system. And to summarize these dynamic properties, I am going to show you these 3 graphs. On the top, you can see the tidal volume, in the middle, the behavior of the alveolar pressure, and finally on the bottom, the pleural pressure. If you follow the orange line, it is very interesting to see that we need a negative alveolar pressure at the beginning to increase the tidal volume inside of our lungs. And this is produced by producing a more negative pressure in the pleural space. And this is due to the contraction of the respiratory muscles. The difference between the orange graph and the green one is the transpulmonary pressure. As I previously mentioned, if you follow the tidal volume curve, the maximal tidal volume represents the maximal difference between the alveolar pressure and the pleural pressure. In other words, these represent the maximal transpulmonary pressure, and every single tidal volume is related with every single transpulmonary pressure. As a consequence of that, the air always flows in favor of a pressure gradient. This is something very well known by a plumber. To move water, we need a pressure gradient. If not, the water will be completely stopped. So to know, this is another consequence, to know that the air is inside, really inside of the alveoli, we need to see a zero flow period at the end of the inspiratory time. If not, the air is still moving from the outside to inside or vice versa. And in this case, second case, we are going to produce air trapping. The summary of these dynamic properties of the respiratory system is the resistance. This is another constant. And if we go down to the graph, the pressure time curve in a volume control mode, as I previously mentioned, the difference between the peak pressure and the plateau pressure represents or is the surrogate of the resistance. This resistance depends the majority of the times of the endotracheal tube size, and in a small infant with a 3.0 endotracheal tube, this resistance is very high. It depends on the radius of this endotracheal tube. Well, from a practical point of view, how can we understand this resistance concept in our clinical day? Well, this is very well connected with the pressure support concept. So imagine you have a patient with a neuromuscular problem, and this patient is not able to decrease the pleural pressure below -7, for example. So it is not able to introduce more tidal volume that those produces by the diminution of the pleural pressure to -7. Imagine afterwards we have an obstruction. So this patient has an asthma attack. In the first case, to move the air, the normal air, the patient can be in a good condition with a normal CO2, etc., normal pH. But in the second point, in the middle, once we have this obstruction and the patient is not able to diminish this negative pressure, we need more pressure, as you can see here, more gradient of pressure to introduce the air and to save this obstruction. This is going to produce more work of breathing, or if the patient is not able to decrease this negative pressure, is going to produce a respiratory failure. What is the solution of this puzzle, this problem? The best solution to solve this problem is to increase the alveolar pressure, for example, using a non-invasive ventilation, like on the right-hand side. In this case, if we increase the alveolar pressure, but just during the inspiratory time, we can decrease the work breathing clearly. And this is summarizing this graph. I am trying to explain how the pressure support works. For a better understanding of the pressure support, it is better to think in a turbine. Imagine the ventilator as a turbine, like the non-invasive ventilators. The pressure support needs different things to set. First one is the inspiratory trigger. The inspiratory trigger detects the inspiratory effort of the patient. But the turbine is working like this. This velocity of the turbine maintains the lower pressure, the EPAP. But once the ventilator detects the effort of the patient, or using the inspiratory trigger, the velocity of the turbine is going to change from this point to this point. And we can move from one velocity to the other like this or like that. So we have another concept here included in this behavior, which is the ramp, the rise time, the slope. So the slope, the rise time, the ramp is the velocity with which we change from the low velocity, so the low pressure, the EPAP, to the high pressure, the high velocity of the turbine, IPAP. But we need another parameter in this pressure support, which is another sensor which detects the diminution in the inspiratory flow, and this is the expiratory trigger. If we have a very good ventilator which can increase the alveolar pressure, but just during the inspiratory time, we are going to decrease the pressure, the work of breathing, and this is the pressure support concept. I know that you know very well these three systems, therapeutical options to fight against the respiratory failure, the work breathing. One is the high flow nasal cannula, the second is the CPAP, the final one is the NIV, or bi-level positive airway pressure. In other words, it's always based on pressure support. Well, we have different mechanisms suggested to explain the different therapeutical options. One is the CPAP effect. For example, in a bronchiolitis, we know that the CPAP, which probably works very well, the level of CPAP which works very well is in between 6 to 8 centimeters of water. It's based on these papers published by the French teams, Sandrine Souris, Christophe Milesi. 7 is a good number to remember. But our problem here is that with a high flow nasal cannula, I'm sure that many of you use high flow nasal cannula, we have a non-predictable and non-measurable CPAP. And this is highlighted in this very fantastic paper published 3 years ago by the Massimo Antonelli team. And if you review this paper, it is a fantastic, I said, there's a fantastic randomized control trial. They compare high flow nasal cannula, CPAP, and 2 levels of pressure. And first of all, they found an interesting finding that this is all patients needed or wanted the same transpulmonary pressure. They wanted to move exactly the same tidal volume. But the only therapeutical option which decreases really the pleural pressure is the non-invasive ventilation. So this is the only therapeutical option which is going to decrease the work breathing due to an increase of alveolar pressure. And apart from that, only NIV and CPAP can increase the recruitment, so they have a real CPAP effect. But the high flow nasal cannula does not have this CPAP effect. And this is something highlighted by, I know that you know very well, Robin Derkemani, and he demonstrated this in this other paper. Finally, to summarize all the two constant, the compliance and the resistance, we have another concept, which is the time constant concept. This is not a concept from mechanical ventilation or respiratory physiology. This is a concept from physics. And I'm going to explain in a very simple manner this concept using the Maxwell model. You remember, this is a spring connected to a damper, and you can figure out that if you push down the spring a certain distance, we need a certain amount of time to displace the damper the same amount of distance. And if the spring is rigid, we can move very quickly the damper. If the spring is very elastic, we need more time to move exactly the same distance in a damper. In other words, this is a exponential behavior, and the engineers know very well this exponential behavior. This is the summary of the time constant, for example, in a pressure control mode. One time constant represents the 63% of the complete to complete the movement of the air from outside to inside and vice versa, to complete the process. To complete the process, we need 5 time constant. To complete the 99% of the process, we need 5 time constants. This is something that you have every single day. So when you, for example, you take a shower. If you take a shower in the morning, you put your hands down in the water, and you need to wait to feel the water enough hot. How many times you need to wait? Exactly 5 time constant, because this is an exponential process and depends on the distance that you have the heater in your house, depends on many types, how strong is this your heater, depends on many types, but this is also an exponential process. The time constant in our respiratory system is the product of the compliance and the resistance. You have the compliance there, the normal value, you have the resistance, the normal value for endotracheal tube of 3, and the time constant, the normal value is in between 0.15 to 0.2. But the most important thing, or the most important conclusion for this time constant is not the concept itself, is how can we use this time constant concept in our day, in front of our patient. It's just because we can identify ventilatory patterns. We have in pediatrics, we have things that can increase the resistance and things that can increase decrease the compliance. But the behavior of the compliances we can only have a normal compliance or a low compliance. We don't have never high compliance. And on the contrary way, in an obstructive pattern, we can only have normal resistance or high resistance. In other words, if we have a patient with a long time constant, the only possibility is because the resistance is high. On the contrary way, if we have a very short time constant, the only possibility is because the compliance is very low. And these are the objectives. I don't have enough time to explain deeply the strategies for obstructive pattern and restrictive patterns, but in obstructive pattern, the objective is to assure that the type of volume reaches the alveoli and, of course, avoiding air trapping during the expiratory time. And the objective in a restrictive pattern is recruitment. In other words, as we previously mentioned, try to ventilate the patient always above the functional residual capacity. And this is my last slide before the conclusions, because in this slide, I summarize the 3 patterns, a normal pattern, and you have down the normal values for a normal pattern, a peak pressure of between 12 to 20, a plateau pressure in between 10 to 15. This is the representation of the compliance. Don't forget that the compliance is the subrogate of the compliance is the difference between the plateau pressure and the peak pressure measured in static conditions. This is the driving pressure. And you have the driving pressure down, and the normal value is in between 7 to 15. And the difference between the peak pressure and the plateau pressure represents the resistance, and the normal resistance due to the resistance of the endotracheal tube is in between 2 to 5, more or less. If we have high resistance, this means that we are going to have high time constant, and this is just because we have an obstructive pattern. And on the contrary way, if we have a very low time constant, this is just due to a very low compliance. And this is my final slide. These are the conclusions. In my opinion, we should not ventilate diseases, we should ventilate patterns and adapt our respiratory strategy, ventilatory strategy to these patterns. We should recover the function residual capacity in every single patient in the world and ventilating this patient above the lower inflection point, but not producing overdistension, ventilating your patient below the upper inflection point. So thank you very much. And you have more information about this talk in this handbook of pediatric and neonatal mechanical ventilation published by the European Society of Pediatric and Neonatal Intensive Care. Thank you so much.
Thank you so much, Dr. Medina, for the excellent lecture. The physiology concepts were very clearly explained, and I think it sparked a lot of questions in my mind, but I'll save that for later. So for now, if I summarize for the audience, we first examined the static properties of the respiratory system. We saw the relationship between the transpulmonary pressure, the alveolar pressure, and the pleural pressure. And we looked at lung volumes and capacities and the transpulmonary pressure required to achieve some of these lung volumes, like the residual volume, the FRC, and the total lung capacity. And it's good to have some of these figures, if just for guidance in our minds. We saw the static pressure volume curves for the lung and then for the chest wall. And then we saw the composite curve, what it looks like when we combine the lung and the chest wall, and appreciating the difference between the adult and the infant curves, as well as appreciating the lower inflection point and the upper inflection point and the slope. And we saw examples of health and disease, and the examples were in asthma and ARDS. And we were to aim to ventilate patients in between these 2 points. And then we went on to look at the dynamic properties of the respiratory system. And we saw the equation for resistance. And I thought you were going to include gas density because it may be relevant as a diver. But besides that, we appreciated the resistance was inversely proportional to the fourth power of the radius. And especially relevant, this is for pediatric airways and for small endotracheal tubes. We saw that resistance can be observed between the peak pressure and the plateau pressure difference. And we saw how the intrapleural pressure falls during inspiration and how this can be exaggerated when there is airway obstruction. And how non-invasive respiratory support can reduce this exaggerated negative pleural pressure, which is required to achieve the driving pressure and the movement of air into the obstructed airways. And you also presented how pressure support or the IPAP component predominantly reduces the work of breathing. We didn't spend that much time on the EPAP component, but this can also support and improve the FRC and stabilize the equal pressure point, and it can also reduce work of breathing from that point of view. We saw evidence of CPAP improving the work of breathing in bronchiolitis. There were a few papers presented. And whereas different from CPAP, the high flow nasal cannula actually has a variable and unlikely to be the main mechanism of the CPAP is unlikely to be the main mechanism for benefit in high flow nasal cannula. And we rounded it off by discussing the time constant, which is the time in seconds to inspire or expire 63% of the total volume, and how it can be increased in obstructive airway due to increased resistance and decreased in restrictive lung or poor compliance lung due to the compliance. And the last slide actually showed very nicely the ventilation settings that can help to address the resistance and compliance abnormalities. And I hope everybody took a photo of the last slide for that. Yeah, so I think in my mind, I have a few questions to actually raise here, but we can see what's available on the chat first and then come to mine later. Shall we look at some of the questions?
Hi, thank you very much, Dr. Wong. I'll begin if you don't mind. Thank you very much, Dr. Wong. And Dr. Medina, thank you for your engaging and practical discussion. So you've already generated a number of questions, and I think the first one I'll jump right into is, could you please explain what is the opening pressure and how does it apply to clinical situations?
Oh, maybe I need another hour to explain that.
Well, we'll give you a couple minutes to start.
Well, this is a very interesting topic because probably we need to titrate the beep. And this is a very counterintuitive thing to understand. But if you increase the beep, you have to focus your attention in the plateau pressure. So when you increase the beep and you can open the lower airways, if you decrease the plateau pressure in this moment, this means that you can open this lower this is the representation that you are going to open these lower airways. So the easiest way to evaluate the opening pressure is titrating the PEEP, focused attention on the plateau pressure. And the best PEEP, in other words, the opening pressure, is those which produces the lowest pleural pressure, alveolar pressure, in other words, the plateau pressure. It's very difficult to understand that in few words.
Thank you. I believe my colleague, Dr. Abdul Rahman, has a question.
Yeah, so there's a question in the chat. In an infant with a bronchiolitis with high respiratory rate and low tidal volume, how to address the ventilation when we don't want to paralyze the child? Should we match the rate and try to address the pathology? So imagine if bronchiolitis, someone having his respiratory rate around 50 or 60 with minimal tidal volume, should we match this with the ventilator, or we paralyze and we put them in a different rate, different minute ventilation?
Okay, that's a fantastic question because in pediatrics, we try to avoid the use of neuromuscular blockers. To be honest, I don't understand this approach because in adults, they use a lot of neuromuscular blockers in the very severe patients, and in particular in ARDS. The problem with this is that we need another hour to explain that because it's the consequence of the negative pressure added to the positive pressure produced by the ventilator. This can produce the new concept of SILI, self-inflicted lung injury. And this concept is very related to the transpulmonary pressure. Come on, let's try to explain this in 1 minute. If you remember, the formula of the transpulmonary pressure is the difference between the alveolar pressure and the pleural pressure. When you have the patient under blockers, neuromuscular blockers, the alveolar pressure is real because it's the plateau pressure that you can measure in your ventilator. But when the patient is active, this positive pressure is added to the negative pressure that the patient is doing actually. But we don't know this negative pressure, the amount of this negative pressure, unless you have an esophageal catheter to measure the pleural pressure directly. So the question is better to maintain active the patient, or is better in these cases in very severe patient to paralyze the patient? I think the answer from the adult fields is the second. Many times it's better to paralyze the patient, avoiding this lung injury produced by the high pressures, or avoiding to decrease a lot the tidal volume, because we know that a very low tidal volumes can also increase the mortality rate.
So, thank you. So the next question, Dr. Michael.
Thank you. So in a case of mixed pathologies, imagine a patient with cystic fibrosis and pneumonia. What's the best strategy for PEEP and thinking about time constants?
Okay, that's a great question. And I'm going to ask a question for you, for the audience. Do you think that we have pure patterns, obstructive pattern or restrictive pattern, just isolated patterns? No, this is not possible. So every single patient has a mixed pattern, and our job as a physician, as a respiratory therapist, and as an analysis, is to detect which pattern is the most frequent. I'm sure that in this fibrosis with a pneumonia can have more a restrictive pattern than a obstructive pattern, for sure. So attention in the recruiting lungs. Okay, the important thing is to focus attention on introducing the air and exhaling the air. This is just to keep always in our mind, or have the ability to analyze the time constant. And it is very easy. It's just analyzing the time necessary to exhale completely the air and dividing this time in 5. And this is a very the simplest way to estimate the time constant.
Thank you.
So,
Dr. Abdul Rahman, yeah.
There's in a clinical practice, how can we quickly differentiate whether increased work breathing is primary due to reduced lung compliance versus increased airway resistance, especially in critically ill children? So how can we differentiate it? Is it the lung is less compliance or the airway is resistant?
Oh, fantastic. Well, I forget to include another slide to explain this easy. And it's as I previously mentioned, is you focus attention in the. Can I share my screen again? I'm going to try to find yeah. Okay.
I think your last slide has.
Yeah. In my slides here, in my last slide, you are right. No, this is not. This slide. Okay. Can you see the slide?
Yeah.
Okay. This is the flow time curve in the middle in red. And you have the 3 examples, the normal pattern, the restrictive pattern, and the restrictive pattern. And it is easy to see the difference between the time necessary to exhale completely the air. If you can measure this distance, the time necessary to exhale the air, for example, in the left-hand side, the normal pattern can be 1 second. Imagine this is 1 second. You can take a shot of your screen, the ventilator, and many ventilators, you can stop the screen and you can measure this distance, and you divide this by 5. This is the time constant. And the time constant is between 0.15 to 0.2 is normal. Come on, let's go to analyze the second point, in the middle, the obstructive pattern. And the question for the audience, is this time constant longer or shorter than the normal? is longer. So you need probably 2 seconds to exhale completely the air. And on the third case, it's restrictive. It's very, very short, just 0.5 seconds. Come on. From a practical point of view, you have 2 babies with a meconium aspiration syndrome intubated in your NICU. And you are in front of the ventilator, and you can detect in one of the ventilators a graph like in the middle, and the second like on the right-hand side. Tell me where is the meconium in the patient 1 and where is the meconium in the patient 2. If the time constant is long, the meconium is in the airway. And if the time constant is short, the meconium is in the alveoli. So you cannot ventilate every single meconium with the same strategy because it depends on the time constant.
That's brilliant. Well said.
Thank you. Yeah, love that explanation. Dr. Wong, you mentioned that you had a couple questions up your sleeve, so to speak. Would you care to share one of them with us?
Sure. So I was going to ask about transpulmonary pressure because it's not very common to measure esophageal pressure. So if we can't get the transpulmonary pressure, what can we have as a measurement to estimate the distending pressure and the stress and strain on the lung?
The transpulmonary pressure, you are right. You are completely right. We don't have the majority of the times an esophageal catheter to measure the pleural pressure. But you can estimate directly the transpulmonary pressure if you paralyze the patient. If you paralyze the patient, the plateau pressure is a good representation of the transpulmonary pressure in inspiration. And when you perform an expiratory hold, the real PEEP, the total PEEP, is a good estimation of the transpulmonary pressure during the expiration. So this is the simplest way to estimate the transpulmonary pressure in both cases. When the patient is active, you cannot estimate the transpulmonary pressure, unless you have the catheter, of course.
And for patients who have chest wall abnormalities, like if they're very obese or if they have very bad kyphoscoliosis or edema, those would be the ones whom is quite difficult to segregate the component of chest wall versus the lung.
No, and in this case, the component is you have a very low compliance, but not because a problem in the lungs. You have a problem in the chest wall. But at the end of the day, you need to increase in the case of the obeses, or in the case of, as I mentioned, with an abdominal problem, like necrotizing enterocolitis. At the end of the day, the objective is the same, to increase the PEEP. And this is a problem because in the pediatric field, we have, I don't know, a religion or something like that in our mind that we cannot increase the PEEP above a certain point, for example, 10. And this, we know that this is producing more mortality in some particular patients.
So earlier on, there was a question about heterogeneous lung disease. And if they have a mixed or a combination of an obstructive and a restrictive lung, what is the best sort of ventilation approach for that? So you explained that it's very uncommon to have a very clean, pure obstructive or restrictive lung. Would you also perhaps consider, PEEP titration to find the optimal, compliance resistance?
Absolutely, yes. That's the key point. So the typical mixed pattern is the bronchiolitis. To be honest, do you know what is a bronchiolitis? To be honest, I don't know what is a bronchiolitis, because I have at least 5 patterns of bronchiolitis, 5 or 6. And one of them is a mixed pattern with a obstructive pattern with a not dynamic air trapping, It's more not dynamic air trapping due to secretions or to a lower airway collapse.
Exactly.
And
Exactly.
these two mechanisms are PEEP-dependent mechanisms. So this is perfect because if we have a pneumonia plus with a bronchiolitis with an obstructive pattern, not dynamic obstructive pattern, the PEEP is the solution. And we need to titrate the PEEP. You are absolutely right.
Something slightly different I'm going to ask about the resistance. Some people measure inspiratory resistance and some people measure expiratory resistance. Is it necessary to do that, and when would you do that?
No, it's a very, very, very good question. And I'm going to ask you the question again. What do you think about the time constant? Do you consider that we have an inspiratory time constant and an expiratory time constant? Or is just one time constant in the world? I think it's very interesting because the time constant is a constant. The constant is always constant in a system.
Yeah.
We have only one time constant. The problem is that we need to perform the process to measure the real-time constant, but the majority of the times the people try to estimate the time constant during the expiration. And this is the reason why you can find a lot of methods to estimate the time constant, very very complicated methods. But at the end of the day, we have just one time constant. And you are right in partially because sometimes when we introduce the air, the resistance is a bit different than when we exhale the air. But this is the majority of the times due to a collapsible airway. But the majority of the times in a normal obstructive pattern, for example, the typical obstructive pattern that in a asthmatic patient, the resistance is exactly the same during the inspiration and the expiration.
Earlier, you mentioned about using ZEEP for
Yep.
asthma.
Yeah.
So could I just maybe ask a little bit more about how you would ventilating a patient with severe asthma who gets intubated? Would you start at the ZEEP and then, make observations after that, or would you start at something empirical, or would you measure the auto PEEP and use that as a reference?
Absolutely, that's the solution. And I know that the the pediatricians are not comfortable with PEEP more than 10, but neither with the PEEP lower than 5. So 0 is something, well, be careful with this 0. But in fact, in an asthmatic patient, the patient is breathing above the the function residual capacity. And when you intubate the patient, for sure, this patient is close to total lung capacity. So the recommendation for Tuxen is a very famous doctor from adult field who designed the best strategy for asthmatic patients during the 80s and at the beginning of the 90s. So his final paper, the title of his final paper, I know that you know very well this paper because it's Permissive hypercapnia. You know that title. This is the title of the paper, published in 1992, I think. And in this paper, Tuxen summarized the strategy for asthmatic patients. And he recommended for the very beginning to use SEEP. But just for the beginning, just to check how is the level of the auto PEEP, because for sure we have auto PEEP, and afterwards you can move the PEEP up to maintain the functional residual capacity. Once you be sure that we don't have air trapping.
Excellent.
Thank you for sharing.
Dr. Joseph,
Yeah.
allow me to direct one of the questions to you. It's there's a question in the chat regarding using open suction versus closed suction and loss of PEEP during that time. When using an open suction system, when you don't have the closed suction system, how do you manage to compensate for the loss of PEEP?
I'm sure that Georgina knows better than me this topic. I'm sure. The I'm and I haven't reviewed this topic during the last couple of years, but what I know it is that the open suction and closed suction are more or less similar. And I don't know exactly if we prefer closed suction than open suction. What do you think, Georgina?
I
I don't
think
have a clear answer about that.
certainly clinically, we find that we would tend to, in our unit, use closed suction in patients where we are trying to avoid disconnection. So in those patients that do de-recruit quite easily when we take them off to bag, when we end up having to put them back on the ventilator after a suction and they have increased FiO2 and increased peak for prolonged periods after suctioning. They're the sorts of patients that we tend to use our closed suction circuits on. In practice, we do find that sometimes the closed circuit suctions just don't seem to clear the secretions as well as doing an open suction. The most important thing, I guess, is your bagging technique then. So when you've got the patient off the ventilator, that you're maintaining that PEEP and that recruitment throughout that period, really. I think that's the most important piece, is just making sure that those sessions are short and sharp and that you're making sure that you're maintaining that PEEP throughout.
But from an evidence point of view, I don't know if we have a meta-analysis to demonstrate that. I don't know.
No.
Okay.
Dr. Judith, did you have anything to add?
Not really, actually, except that, for patients who are on very high ventilator settings, we would sometimes do, for example, like the PEEP titration, which is in a way a bit of a recruitment maneuver as well, but it's like a stepwise recruitment maneuver. So, it's done, I suppose, often enough that we can time it such that it's done after the suctioning is completed. Because if it's done before and then the patient gets de-recruited after that, it may just defeat the purpose altogether. Yeah, but no, not any evidence I can think of that, how can we ameliorate the loss of, the de-recruitment, loss of pressure upon disconnection.
Yeah, I think they say you lose that recruitment in about 0.6 of a second when you disconnect. So, there's not much hope in kind of maintaining that. As soon as you disconnect, you're going to get some level of de-recruitment. So it's about kind of maintaining that as much as you can through the suctioning process and then back on the ventilator and using those recruitment maneuvers if needed.
Okay, so the last question also related to this topic. So how do you determine the lower inflection point and the upper inflection point? Are you just incrementing the PEEP, seeing the saturation? When it picks up, you're gonna tell roughly that this is okay. When you reach a stage where you see hypotension, saturation is maintained, it's not progressing, that's my upper inflection point, and you need to go down below it, that you're hyperinflating the lung. Is this the only way that we're using to determine our lower inflection point and upper inflection points?
Well, from a practical point of view, I think that this is not necessary to determine the lower inflection point and the upper inflection point. We need to determine which is the best PEEP level for that particular patient. And the best PEEP level is those, as I explained this before, those with which we have obtained the best oxygenation, best compliant, but with a lowest plateau pressure. And if you increase the PEEP and this increase produces a subsequent increase in plateau pressure, you are going to produce overdistension. So you are above the upper inflection point, going back to the previous PEEP level. This is the summary.
Excellent. Judith, any takes regarding that?
Most of the time, for difficult to ventilate patients, I would I would still do a PEEP titration, a stepwise PEEP titration to actually find the upper and lower inflection point at least once, and then repeat it again when there's a change in the clinical status. So in my practice, I would actually try and get the actual number.
So there is a fantastic question down there, and this is an ongoing discussion. This is the difference between the pressure control and volume control. So a square waveform in a flow or decelerating flow. Probably we need another talk to discuss this, because I'm going to say something. Don't think that pressure control is more physiological than volume control. And even more, maybe because of the new theory, rheological theory based on material science, the peak flow generated in a decelerating flow at the beginning can produce more strain rate, so more damage. Be careful.
Okay, thank you. Blunt?
So,
I don't know. Do we have time for more questions?
yeah.
If
Well, I have a
our
follow-up question to that, just briefly. Does that assumes that we're doing a constant flow rate in the volume control, because many of the newer vents have different flow patterns for
Yeah.
volume?
Yeah, but you're right, you're right. But my problem with the new modes and new ventilators, even with the high flow nasal cannula, is that the regulations, at least in Europe and in the States, you don't need any randomized control trial to demonstrate something in mechanical ventilation to implement this mode in a ventilator. So it is very interesting, because you can find probably more than 300 modes around the world, and none of them are, and even more, I am going to say something. Have you found any randomized control trial using pressure regulated volume control in comparison to volume control? No. Well, I'm saying that last year there is only one paper, a randomized control trial in adults. You cannot find any randomized control trial comparing pressure regulated volume control and volume control. But you can find animals studies in Japan, and with pressure regulated volume control, you can increase more the mortality than in volume control. Sorry, but probably we will have problems with our ethical committee to to run a randomized control trial.
Thank you.
That's interesting.
do we have any more questions to be taken, Dr. Abdul, Dr. Michael, if our experts allow?
Yeah, well, we have a number of questions, so you can tell me when to stop. This is the next one I see up is just a question regarding clinical practice. How can you quickly differentiate between whether increased work of breathing is primarily due to compliance or resistance issues in a critically ill patient?
That was answered.
Yeah.
That was taken, Dr. Michael. I think the question was taken already, and Dr. Medina answered it.
Oh goodness, I'm sorry. So there's a question on the relevance of low-cost bubble CPAP devices. Given that the maximum flow can be 10 to 20 liters, how can you manipulate these devices to meet peak flow?
Well, I think that the high bubble CPAP is a very good device, and maybe we can obtain better results than high flow. And it's exactly well, the cost of the bubble CPAP and the high flow are similar, and both are from the same company. I'm not going to say the company, but you know very well the company. How can we establish the flow necessary for a bubble CPAP? I think it's very simple. You need to multiply the minute volume by 5. And this is the flow necessary for the bubble CPAP. Is this the question or is this something different?
I believe that's the question.
Okay. So 5 times the minute volume. So in a 4 liters per minute of minute volume, you need 30 liters. And if you, for example, use a helmet, it is obligatory to wash out the CO2.
I think that, yeah, just a quick follow-up, but there are limitations, the amount of flow that can be provided in many places. So it's based on your response, and it's not really practical or helpful.
Yeah, this is right. It says depending on the country. But what I did a long time ago, when I use homemade CPAP systems, is to connect different flow meters. So when you need more than 15 liters, that you have normal flow meters, you cannot connect in parallel 2 flow meters. 15 plus 15 is 13 liters, 30 liters. So sometimes we needed to connect 3 or 4 flow meters. But nowadays, I recommend to use turbines. Maybe can be one objective for the World Federation to try to develop a simple and cheap turbine. We developed some turbines for from developing countries during the pandemics. I remember I have some slides there. I remember we use commercial big turbines for the industry. With one turbine of that, we can provide CPAP for 20 patients at the same time. This can be a good project for the future.
Thank you.
So before we conclude, I would just like to announce about the next webinar. So our next webinar is going to happen on 16th of April, and the topic is lung recruitment and prone positioning in pediatric ventilation, and our expert speakers are Brenda Morrow, who's a physiotherapist and full-time professor in Department of Pediatrics at University of Cape Town, and we have a guest faculty, Dr. Peter Riemensperger, who's the head of the department at the Division of Neonatology and Pediatric Intensive Care, University of Geneva. So I would urge you all to join us, and we have a fabulous faculty lined up going forward in these monthly webinars, and we aim to do these monthly over a period of next 1 year at least, so that we cover good important topics about pediatric respiratory critical care medicine. And I would like to thank Dr. Alberto for taking his time and sharing his views, and for such a fantastic presentation, explained so very well. And I'm getting messages from my fellows, colleagues and students back in India here that the talk was very fantastic and they loved learning from you and Dr. Judith. Thanks for joining us, and it was a pleasure listening to you, Dr. Alberto, and we would like to be associated with you, and we would like to invite you again for our upcoming webinars going forward. Thank you, Dr. Judith, for taking out your time and being and agreeing to be a guest faculty for today's webinar. So please do join, and also I would urge you all to share these webinars, and the recordings are available on WFPICCS YouTube channel and the website, and the upcoming webinar Zoom link for registration has also been shared in the chat box. So thank you so much. Thank you, Dr. Alberto.
Thank you so much. And this is my final slide.
Bravo, bravo.
Thank you. Bye-bye.
Thank you so
Thank you.
much. Bye-bye.
Bye.
Thank you.